optimal management of bronchial asthma in the clinic. So, Dr. Wael, thank you very much.
Thank you. Assalamu alaikum wa rahmatullah. So I've been given this tremendous task to present the optimal management of bronchial asthma in the clinic. And this, trust me, one talk is not adequate to give this subject its rightful discussion. I have no real or perceived conflict of interest to declare regarding this presentation. And these are my objectives today. Hopefully I'll try to finish in the allocated time. Asthma is a heterogeneous disease as defined by GINA, which is usually characterized by airway inflammation and is defined by a history of respiratory symptoms, as we all know, such as wheeze, shortness of breath, chest tightness and cough that vary over time and intensity, together with variable airway inflammation. With airway limitation. The definition accommodates, as you might all be aware, multiple asthma phenotypes identified by cluster of demographic, clinical, and pathophysiological characteristics that are likely to be different underlying mechanisms. The pathophysiology of asthma phenotype starts in the airway epithelium with the allergen exposure or the pollutant microbes. They present to the dendritic cells, which eventually activate the naive T cells, which eventually activate the T helper 2 cells, producing interleukin-5, which is important for eosinophil maturation, interleukin 13, which is important for goblet cell, as well as smooth muscle hypertrophy and hyperplasia. Interleukin 4 and interleukin 3 play a role in B cell activation in the release, making them an IgE releasing machine, producing significant amount of IgE, which bind to the avid receptor of the mast cells. On further exposure to the same allergen to that mast cell, which is primed with the IgE, the mast cell causes degranulation, releasing tryptase, histamine, and other cytokines. This results in the atopic eosinophilic asthma. However, non-eosinophilic asthma also has a similar pathway, but includes other cytokines and interleukins, such as interleukin 33, interleukin 25, and TSLP, which has recently had a biological treatment. Non-neutrophilic asthma, as you may all know, has a less obscure pathway, and it's normally the involvement of pollutants and microbes, and results predominantly in activation of neutrophils. Asthma prevalence and mortality in the global burden of disease study in 2016, it shows that asthma has 339 million cases globally at the time, with 420,000 deaths during that year. It was labeled as the 23rd leading cause of premature mortality at the time. The problem in the Gulf cluster, it's been estimated that asthma ranges about 7.6%. Uncontrolled asthma, however, poses another problem. It's estimated that in the Gulf region, it's about 38 to 42%. So what are the goals of asthma treatment in the clinic? The goals predominantly look at symptom control as well as risk reduction. And each one of these has its entity. However, the patient's goals may differ from yours. So it's very important that you address these with the patient. Find out exactly what they want in terms of their asthma control. This is done usually by following asking the patient, good communication skills, and considering other healthcare systems such as medications availability, cultural and personal preferences, and health literacy. If we take Ms. J, for example, a 35-year-old lady who attends your clinic, a smoker, a 40-pack year history, and has a BMI of 37. She visits the outpatient clinic, having been diagnosed with asthma about 10 years ago. Her past medical history of interest on hypertension, allergic rhinitis, and gastroesophageal reflux disease. She's taken an ICS LABA, and you've noticed that she's got poor inhaler technique. She's also on an add-on therapy, Montelukast, and she takes Ventolin, she tells you, on a daily basis. She states that she had 3 exacerbations in the last year requiring oral corticosteroids. You perform an ACT, and her ACT score asthma control test is 15. You perform spirometry, and it shows moderate airway obstruction with an FEV1 of 59%, But interestingly, you do reversibility. And despite taking her salmeterol and fluticasone that morning, she performs very good, 12% reversibility. So you kind of wonder whether she's taking it correctly. You also do a pheno and eosinophil, and they come back later on, showing that she might have type 2 high asthma. So that case, you really kind of wonder, where do you start? But you have to go back to the basics. And asthma control, like we said before, it's 2 domains: symptom control, which is the last 4 weeks, as well as risk factors. So you could use any tool to assess asthma control. I prefer the asthma control test, which has 5 domains and reviews the previous 4 weeks. These domains include activity limitation, shortness of breath, night awakening, reliever medication use, as well as global judgment of asthma control by the patient. Very poor control is between 5 and 15. Very well or optimal control is more than 20, more or equal to 20. So assessing the risk, which is the second domain of asthma control management, is looking at exacerbation, risk of exacerbation in your patient, looking at persistent airflow limitation, which might complicate their asthma, and medication side effects. The risk for future exacerbation starts with poor asthma control at the start, but also a low lung function test. So an FEV1 of less than 60% or a high bronchodilator responsiveness at the time is suggestive of poor asthma control and a risk for future exacerbations. There are items regarding medication use, such as high SABA use, as well as inadequate ICS treatment, and which is currently been incorporated in the 2 tracks for Bigena. You need to also check poor adherence and inhaler technique, as well as other comorbidities, which are quite significant. Exposures that you need to look at those, as well as whether they have a T-high inflammatory response, history of exacerbations in the past year requiring oral corticosteroids, or even a history of admission to intensive care or being intubated. The risk of having persistent airflow limitation depends on ongoing exposure to cigarette smoking and noxious agents, especially occupational asthma, and chronic mucus hypersecretions, as well as asthma exacerbation, but not taking an ICS. You need to address with your patients medication side effects, particularly those pertaining to high-dose inhaled corticosteroids or oral corticosteroids. These patients would require performing a DEXA scan, either 6 monthly or yearly, to make sure they do not develop osteoporosis. You also need to be on the lookout for adrenal suppression, which might have subtle signs or symptoms on presentation. So, like we said, where do we start with Ms. J? She's a smoker. She has a high BMI. I suspect she's probably got obesity, obstructive sleep apnea, but that's not been addressed in the history or the examination. You might also want to address why she's not on treatment for her allergic rhinitis, as well as gastroesophageal reflux disease. You're a bit worried about Ventolin being used on a daily basis, and you're also worried that she's on Ramipril and Gaviscon. The Ramipril might be causing her a bit of cough, and Gaviscon, which is not really an adequate treatment for gastroesophageal disease. Her 3 exacerbations in the past year is a cause of concern, as well as her current ACT score of 15. The most important part I'm worried about is the reversibility of 12% in a person who's taking an ICS LABA. So you think that there is room for actually optimizing her treatment, definitely. So in your assessment, you say that Mrs. Jones had poor control asthma. Her asthma is difficult to treat due to modifiable factors that should be addressed. She also has several unmanaged comorbidities and risk factors for future exacerbations. Just highlighting the current GINA guidelines, which provides the options of using track 1 or track 2 with ICS formoterol in the first track to use as needed, followed by using it as a maintenance and reliever therapy in step 2, 4, and 5. So you would like to change Ms. J into one of the, probably in track 1, and start giving her an ICF formoterol and ask her to use as maintenance reliever therapy. You would like to assess her again in about 3 to 4 months to see if things have changed. So the problem solving is the first principle of control. So we need to address all of these factors which were present in Mrs. J: poor medication adherence, poor inhaler technique, possibly ongoing exposure, and comorbidities. Or maybe even an incorrect diagnosis. That always has to be at the back of your head. You always need to take a step back. Giving treatment after treatment is not the right thing for asthma. You need to consider whether you've optimized that step and move on to the next. You need to find out what is actually the condition is causing this patient's symptom. Is it their asthma driving their symptoms? Is it their obesity? Is it their sinusitis? Is it something else? And you need to address all other comorbidities. As we know that severe asthma is only 3.7% of the population, while difficult to treat asthma is about 17%. And that needs to be addressed on these modifiable and reversible risk factors. So before you jump on the wagon of, yes, it's severe asthma, I'm going to give them biologic, you need to look at treatment barriers that you've got in your patient, comorbidities, exposure, and again, is it something else? So systemic assessment of asthma is the way forward in order to not miss anything. So diagnosing and phenotyping, treatment barriers, addressing of treatment barriers, as well as modifiable aggravating factors. This is a paper, a systematic review, a meta-analysis with Peter Gibson and Ian Pavard, looking at the multi-assessment of asthma, which suggests that looking at various parts, comorbidities, airway pathobiology, risk factors, and self-management. There is evidence that if you do a one-day assessment of severe asthma, you reduce the patient's symptoms on follow-up visits. The multidimensional assessment of asthma also, that review showed that this assessment is quite essential in controlling your asthma patients. So confirming the diagnosis, just going back, confirming the diagnosis, going over the history again, because you know about 25 to 35 patients with a diagnosis of asthma in primary care do not have asthma. You do that by actually demonstrating variable airflow obstruction with various ways: spirometry, reversibility due to prednisolone, peak flow variation FEV1 over time. So if they come in clinic with one FEV and the other time they come in with a different FEV, that's also helpful in diagnosis. Bronchial provocation tests, if available, such as methacholine or mannitol challenge, and significant fall following exercise, or excessive variability between visits, like we mentioned earlier. It becomes a problem sometimes in patients who've got a confirmed, who you need to confirm diagnosis of asthma of already on treatment. So you need to go back on the treatment. You need to assess, adjust, reduce their steroids by 25 to 50%, and reassess them again in about 2 to 4 weeks. Review the response. So when is asthma not guilty? There's a wide differential diagnosis of what could be the possibility. It could be asthma, but it could be asthma with another thing, asthma plus syndrome. It could be vocal cord dysfunction or dysfunctional breathing to start with. So asthma might not be guilty. It could be COPD. It could be other whole host of problems. I've seen a fair share of patients presenting with asthma-like symptoms, and we've done a CT scan to assess them. We found that they're actually got tracheobronchomalacia confirmed through bronchoscopy. I'm not saying that these symptoms do not present with asthma, but it's worth keeping them an open mind, because you could offer your patients, offload them of medication, and start them on other treatment, such as congestive cardiac failure. Doing a BMP and echo is also a benefit. So GNL recommends that when you have a difficult to treatment asthma, you'll go back, confirm the diagnosis, you look for other contributing factors like we did, and you tackle suboptimal adherence. So this is a major problem. Always document adherence and tackle it. If you've got an electronic prescribing registry, check if they're taking their medications. Indications of poor adherence as well. You might be able to do their own oral corticosteroids to check if their blood serum prednisolone level and other medications as well. So we assess adherence because it tells you about your patients. Interesting story about your patients. You address it to reduce unnecessary prescribing, obviously, and achieve better clinical outcomes, as well as other factors. You might consider a once daily regime, reducing their inhaler, using combination inhalers, and that might support your patient by staying adherent to their medications. I always check inhaler technique in my clinic. You ask your patient, show me how you use your inhaler, and you might be surprised on the problems that come from asking that question. There has been various studies showing that critical errors in inhaler technique was associated with increased risk of asthma exacerbation, hospitalization, and ER presentation. So it's of paramount showing the correct inhalation technique to your patients rather than choosing actually the medication itself. You could use that as a checklist. In my clinic, I've got, I show my patients, everybody's got a mobile phone, so I ask them to take a picture of this barcode, and there's a video of every inhaler in the world that they could be using. So that kind of reminds them on how to use their inhalers. So you have to follow a strategy in terms of to ensure effectiveness use of inhaler. You need to choose, check, correct, and confirm the correct inhalation use. So encourage the patient to participate in the choice, show them various inhalers, MDI or a dry powder inhaler, an easy inhaler, and you might want to demonstrate it as well. Check their technique and correct the technique on each visit. When they come to you, ask them to bring their inhaler, spend that extra 5 minutes seeing how they're using that inhaler. If you've got also, this is a study showing that healthcare professionals can improve patients' inhaler technique and improve their asthma adherence and control. There are non-pharmacological factors which would help control asthma that you need to tackle in your clinic, such as weight reduction, breathing exercise, as well as avoidance of indoor air pollution, as well as avoidance of outdoor allergens, with limited evidence, and dealing with emotional stress. Going back to the weight reduction factor, there's good evidence of getting bariatric surgery with the striking results in asthmatics. However, even if your asthmatics lose about 5 to 10% in their weight, that improves their asthma quality of life and symptoms. Asthma education is quite essential in order to maintain adequate control. There's a study based in the US and Canada which showed that a program for children 5 to 18 years was associated with 30% reduction in ER visits. You need to provide your patients with an asthma management plan, and that needs to be reviewed on each clinical visit. You need to look at exposures. Does your patient still smoke, and how can you help them in that? Allergens as well. This is difficult as there's limited evidence really on how to assess and reduce allergens. The allergen avoidance currently is not recommended as a general strategy in asthma as evidence A by GINA. You need to assess also their medications. Are they taking non-steroidals, aspirin, beta blockers, or ACE inhibitors, and the occupational exposure, such as ongoing exposure to flour grain, isocyanides, formaldehyde, and other items. So the major issue actually is trying to tackle the comorbidities, and you could try to diagnose rhinosinusitis and nasal polyps, as this is quite prevalent, 50% allergic rhinoconjunctivitis. So consider doing the SNOT-22 questionnaire, CT of the sinuses, or refer them to the ENT for optimal assessment. History of smoking as well, you need to assess that. You need to look at whether they've got dysfunctional breathing and do an management questionnaire. So there's various comorbidities that you need to untangle in your patients. This is one study looking at the impact of OSA on asthma symptoms, which shows that asthma symptoms is poorly controlled in people who've got OSA. So you might need to do an overnight sleep study and commence them on CPAP therapy. So you've optimized your patients by reviewing all these factors that we've talked about, but they continue to be asymptomatic. Then you have to step them up to step 5 by adding a LAMA, or even consider phenotyping them and considering other add-on therapy. You might want to consider whether they would benefit from immunotherapy and refer them to an allergist. As we already know that step 5 recommendation suggests that adding a LAMA into a medium or a high dose ICS LABA will improve lung function. However, it does not improve symptoms. It also improves exacerbation rates. Azithromycin, it's one of my wonder drugs, which I like to give to my severe or difficult to treat asthmatics, as it has an immunomodulatory and anti-inflammatory mechanism of action and helps improve asthma control. So assume you've done all that and things still are not getting better. So you have to question, is this still uncontrolled asthma, or are we kind of approaching severe asthma, the 3.7%? So as we all know, the definition of severe asthma is now defined as uncontrolled despite adherence with maximal optimized therapy. So that is high-dose ICS-LABA and treatment of contributory factors. It's about 3 to 8% of your asthma population. However, it has a 50% health cost of expenditure. If you feel that your asthmatic is severe, you should consider by that time to perform these tests, which includes IgE, fungal precipitants, HR-CT scan if not already done, DLCO, as well as an ANCA, CT sinuses, BMP, and bronchoscopy. So once you phenotype your patients, you further optimize treatment and reassess them again to see if they would benefit from type 2 biological therapy. As remember that the asthma phenotypes, you have to have type 2 high and non-type 2 asthma, atopic and non-atopic. So your type 2 is the allergic early onset asthma, and this is IgE predominant, which benefits from anti-IgE therapy. You need to also look at other non-atopic asthma and consideration of anti-IL-5, anti-IL-4, and anti-IL-13 medications. The non-type 2 would benefit from adding LAMAs as well as azithromycin, like we spoke about earlier.
2 minutes, please.
Okay. So you need to consider using biomarkers. Some of them are easier to find than others. But if you do a pheno, total IgE, and blood eosinophils, you'll probably get most of the answers for your type 2. So what is available in terms of biological therapy? We've got anti-IgE, anti-IL-5, and anti-IL-5 receptor, anti-IL-4, and the new kid on the block, anti-TSLP. So this is kind of a summary of what targeted biological treatment is available at the moment. And these are the criteria for starting them. So again, you start treatment with biological therapy, your asthma patients continues to be symptomatic. You need to reassess again, go back, see what's been missed, review the diagnosis, consider add-on therapy as well, such as macrolides, low-dose steroids, or thinking of a different diagnosis. Checking their inhaler technique is even if you start them on biological therapy, going back to the basics is quite important. Checking their adherence, comorbidities, which could prove as a challenge, and you have to communicate with other health professionals about your patients with severe asthma. So in summary, I'd like to say that optimal management of asthma in clinic should include a multidimensional systematic assessment to help identify treatment barriers, disease triggers, and unmanaged comorbidities. Thank you for listening.
Thank you very much, Dr.